DCIS. DCIS is on a spectrum of abnormal cells. It is a risk factor for later invasive cancer. 30% of transformation to invasive cancer in 10 years. There's approximately 3% breast cancer mortality at 20 years from DCIS. In terms of types of DCIS, it's basically separated into comedo, which is the most aggressive, and non-comedo, which include the following: solid, cribriform, papillary, and medullary. Local recurrence risk factors after DCIS include close or positive margins, age less than 40, so young age is not good, high grade, size greater than 4 centimeters, the presence of comedo necrosis, which again is the most aggressive and multifocality. There's a Van Nuys risk criteria, which predicts recurrence: 1, 2, or 3 points, GRAMS, grade, age, margin, size. Again, 1, 2, 3 are points. 1 to 2 no necrosis would be grade 1, grade 2, score of 2 for grade is 1 to 2 plus necrosis, and then grade 3 is a 3. Age 1, 2, and 3 is greater than 60, 40 to 60 or less than 40. Margin, a score of 1 is greater than 10 millimeters. Score of 2 is 1 to 9 millimeters. Score of 3 is less than 1 millimeter. Size is separated 1.5, 1.5 to 4, and 4 for 1, 2, and 3. The sum of less than 6 has a local failure of 10 years at less than 5% with or without radiation. The sum of 10 to 12 has a 10-year local failure at 50%, 40% of which are invasive. Things you want to know about pathology: grade, extensiveness, ER/PR status, and margins. 2 millimeters is sufficient per ASTRO consensus. If there's LCIS or ADH on initial biopsy, do an excisional biopsy or a lumpectomy, because 20% will be associated with DCIS. Risk factors associated with elevated risk of ipsilateral breast tumor recurrence: EORTC 10853, age less than 40, clinical detection, positive margin, solid type. Per NSABP B17 and B24, it's age less than 45, clinical detection, comedo necrosis, and margin status. In terms of management of DCIS, obviously you always get an H&P with pregnancy testing, a diagnostic mammogram with a core needle biopsy. After a screening mammogram usually picks this up. Consider an MRI for dense breasts. Do a pathologic review, ER status determination, genetic counseling if appropriate. DCIS, ONRT, and Oncotype DX are commercially available tests that may be helpful in that they provide further risk estimates. Oncotype DX DCIS is validated from this Solon trial. This ECOG 5194 predicts for both the non-invasive and invasive recurrences. ER and HER2 were not included in the 12-gene analysis, but PR is. Contraindications to radiation for DCIS. Absolute contraindications include pregnancy, diffuse microcalcifications, widespread disease that cannot be removed by local excision of a single region with negative margins and satisfactory cosmetic results, persistently positive margins, not at an anatomic border like a skin or chest wall, homozygous for ATM or collagen vascular disease. Relative contraindications include prior radiation, genetic predisposition to breast cancer, as they may have increased risk of recurrence with breast conservation surgery, but Laurie Pierce data suggests no increase in ipsilateral breast for BCS compared to mastectomy if they also get a prophylactic TAH-PSO. Having said that, first treatment paradigm is lumpectomy without sentinel node biopsy, followed by post-excision mammogram with whole breast radiation, plus or minus a boost, and consider endocrine therapy if they're ER positive. Lumpectomy, you want negative margins or else you re-resect. 2 millimeter margins is sufficient. Double margin, or positive margin rather, doubles the recurrence rate. No sentinel node biopsy. You want to know the grade, the margins, the ER status, the size. If it's a persistently positive margin, go to mastectomy. Post-excision mammography and lumpectomy specimen radiograph to check that all the calcifications are out. Whole breast dosing, you can do standard or hypofractionated whole breast. Hypofractionated whole breast is supported by MD Anderson Scheitelman 2015 data, 1525 versus 42.56 and 16, showing decreased acute grade 2 tox, improved quality of life, and less fatigue with hypofractionation. Boost. There are no randomized trials for boost in DCIS. Is only done for invasive disease, but you can extrapolate that there may be a benefit. There are also retrospective publications suggesting a local control benefit, approximately 3% better local control at the cost of increased toxicity with fibrosis telangiectasias. Per ASTRO 2018 guidelines, consider boost for age less than 50, close positive margins are high grade. Endocrine therapy only if they're ER positive, tamoxifen 20 milligrams daily for 5 years, or anastrozole 1 milligram daily at postmenopausal and less than 60 years old. Another option is a simple mastectomy plus a sentinel node biopsy. Consider endocrine therapy for other if ER positive. Simple mastectomy is removal of the breast tissue, no axillary nodal dissection, no pec muscle removal. If you're doing a mastectomy, you can consider sentinel node biopsy because we would want this if the path came back unexpectedly invasive. 3, lumpectomy, then observation. This is category 2B per the NCCN. See evidence for this at the right. Just know that radiation reduces recurrences by 50%. Half of those are DCIS, half are invasive. All trials show a local control benefit to radiation, though no survival benefit, but absolute benefit in selected patients may be small enough that they opt to omit radiation. Consider it for negative post-excision mammo, a focus of DCIS that's less than or equal to 2.5 centimeters, lower intermediate grade, no necrosis, greater than 3 millimeter margins, age greater than 60, willing to take 5 years of tamoxifen if they're ER positive, or anastrozole, willing to accept the increased local recurrence risk. These groups essentially mimic the RTOG and EORTC inclusion criteria. Fourth option is lumpectomy, then accelerated partial breast irradiation, then consider endocrine therapy. Per APBI, suitable includes age greater than 50, screen detected DCIS, lower intermediate grade, less than 2.5 centimeters, resected with margins of at least 3 millimeters. ER positive, no LVSI. Retrospective registry data suggests this approach may be okay. Mainly DCIS was excluded from most of the published randomized APBI trials except for GetGastro. In terms of evidence, the benefit of radiation after lumpectomy. So these are trials looking at lumpectomy followed by radiation or no radiation. 4 randomized control trials, NSABP B17, EORTC, UKCCR, and Swede DCIS. None used a boost as part of their trials. There's no randomized controlled trial comparing mastectomy to breast conservation, unlike an invasive disease. There is a meta-analysis of these 4 trials that shows local control benefit for radiation is 30% versus 15% without tamoxifen, or 20% versus 10% with tamoxifen, but again, no survival benefit. The bottom line is that whole breast irradiation after lumpectomy in DCIS results in a 50% reduction in ipsilateral breast recurrence. Trials looking at the role of omitting radiation, a subset. Note, age is not a criterion in these trials. They included women in their 30s. RTOG 9804 from Beryl McCormick is the only randomized trial we have of this. 585 mammo detected, low grade, meaning 1 to 2 DCIS. Again, excellent criteria, right? Size less than 2.5 centimeters, margins greater than 3 millimeters, but no age restrictions. They got a lumpectomy and then either 50 or 42.5 and 16 whole breast. 10% had the hypofractionation, so most of them actually got 50 and 25 versus just observation. Tamoxifen was optional, no boost was allowed. The 7-year ipsilateral breast tumor recurrence for observation was 6.7 versus 0.9 for those that got radiation. The bottom line from RTOG 9804, whole breast radiation for low-risk DCIS improves ipsilateral breast tumor recurrence. IBTR continues to rise with follow-up. We now have 10 and 15-year follow-up data on this. Decision-making may be individualized. The next is ECOG 5194, Solon, JCO 2015, single-arm prospective. Again, RTOG 9804 is the only randomized trial. ECOG 5194 is prospective follow-up of 2 DCIS cohorts after lumpectomy. No radiation. Tamoxifen was optional. It was used in about 40%. The follow-up is for lower intermediate grade, less than or equal to 2.5 centimeters versus high grade, less than or equal to 1 centimeter. Both groups had good margin status, greater than or equal to 3 millimeters after wide local excision. The 12-year ipsilateral breast tumor recurrence was 15% for this cohort A and 25% for this cohort B. So again, this is a single-arm prospective trial showing that low and intermediate grade DCIS may be safe to observe after whole breast radiation. Ipsilateral breast tumor recurrence in high-risk DCIS seems elevated enough to benefit from whole breast irradiation. And this shouldn't say after, this should say maybe instead of whole breast radiation. Again, nobody had radiation on this trial. Harvard wide local excision by Wong, but instead of Harvard wide local excision, Wong et al., JCO 2006. This is DCIS after wide local excision, grade 1 to 2, greater than 1 centimeter margins, no radiation, no tamoxifen. 5-year local recurrence was 12%, 8-year local recurrence is 13%, local recurrence increased at a rate of 2.4% a year. 2/3 of recurrences were DCIS, 74% occurred in the original quadrant. Bottom line is local recurrence is substantial without radiation and tamoxifen, even if wide margins are taken. Studies looking at the role of endocrine therapy. The first is NSABP B17, WAP-NIR, JNCI 2011. This is about 2,000 patients after wide local excision for DCIS, including patients with positive margins. ER positive or negative allowed. They either got 50 gray plus tamoxifen times 5 years versus 50 gray alone. 38.5% got a boost. 5-year invasive disease for 50 gray and tamoxifen was 4% versus 7% for 50 gray alone. Bottom line from NSABP B17 and B24 is that tamoxifen added to radiation reduces ipsilateral invasive breast cancer among all patients before ER was assessed in DCIS. When you're testing ER status, ER positive tumors had reduced total invasive cancer events with tamoxifen, although isolated effects were small. This better local control benefit with radiation compared to tamoxifen is why radiation for DCIS is category 1. Tamoxifen functions to reduce total bilateral and contralateral breast recurrences. There's non-significant interactions at individual sites, including ipsilateral breast for both or either invasive breast cancer and DCIS. Tamoxifen may be merely tumorostatic, not tumoricidal. 16% of these patients have positive margins. Post hoc analysis of NSABP B24 ER positive showed a decrease in total breast cancer, total invasive breast cancer, any contralateral breast cancer at 10 years, but not ipsilateral recurrence of any kind. On multivariate analysis, those ER positive individual benefits were small and not significant in DCIS recurrence alone or ipsilateral recurrence for invasive breast cancer, DCIS, or both. The next trial is UKCCR, aka UKANZ by Cusick. This is DCIS after resection with negative margins. They either got observation, tamoxifen times 5 years alone, radiation of 50 gray, or radiation plus tamoxifen. The 10-year ipsilateral breast tumor recurrence, 17% for OBS, 13% tamoxifen alone, 2.6% radiation, 2.4% radiation plus tamoxifen. Radiation reduced both ipsilateral invasive and ipsilateral DCIS. When radiation is given, tamoxifen had no benefit on ipsilateral invasive or ipsilateral DCIS disease, or even contralateral tumors. The bottom line from this UKCCR or UKANZ is that whole breast RT for DCIS improves ipsilateral breast tumor recurrence. Long-term tamoxifen does not reduce ipsilateral or contralateral tumor recurrence when radiation is given. However, that study was done prior to the receptor era, and endocrine results may not be applicable in that setting. Tamoxifen versus anastrozole for postmenopausal patients is NSABP B35, Margulies, lumpectomy, then radiation. Then tamoxifen versus anastrozole for postmenopausal DCIS. There were slightly fewer new breast events for anastrozole, but only in the patients less than 60. Ovarian suppression with Lupron or goserelin and tamoxifen, or an AI in the premenopausal of high risk, meaning young age and 1 high grade. Premenopausal early breast cancer, the SOFT and TECT trials, tamoxifen versus tamoxifen plus ovarian suppression versus exemestane plus ovarian suppression. TECT was similar, but without the tamoxifen only arm. This is looking again actually at the role of invasive breast cancer. But basically what it showed is that in premenopausal breast cancer, adding ovarian suppression to tamoxifen improved disease-free survival and overall survival. Adding exemestane leads to even better freedom from relapse. The highest risk patients may receive up to 10 to 15% reduction in distant mets. However, ovarian suppression has notable adverse effects. Question is how microinvasive diseases approach treat as DCIS, but you do not favor observation.